So Patrick had eloquently discussed dysbiosis and defined it. We're going to just talk about one piece of it, something we affectionately call SIBO. And it was one of these almost outlawed diagnoses way back in the day, maybe about 10 to 14 years ago when I first started at Johns Hopkins. And now you can't keep up with the patients, you can't keep up with the demand in breath testing. And so I think, again, it's a paradigm shift that I've seen over the years. And it kind of coincided with diagnostic testing for the microbiome and that raising the consciousness of the importance of the biome. And now that we have this entity where we had people with all these diagnoses or symptomatologies that were consistent with IBS, and just thought that it was exclusively IBS, but now we realize that a lot of the symptoms were driven by this dysbiotic environment that we realize is now in the small bowel to a large extent in these people, and we call that SIBO. So with that as an introduction, our objectives as listed in the slide is first to define what is SIBO and then really get into what are the subtypes of SIBO, discuss what is SIFO, which is fungal overgrowth that Patrick had discussed, what the commensal state of having fungus in the stool is, but when that gets out of control and the communities become dysfunctional and the fungi participate in that dysfunctionality, then we need to pay more attention to them. And again, many years ago, that was looked at as being witchcraft or hokey type of medicine. So you'll see this throughout the module. This is the matrix organized in relationship to the biome and the critical or central role of the biome and many of these different physiological functionalities that we are discussing with the microbiome as a center point. So as you go through all the modules, you'll see that there is an interconnection with the microbiome and how it relates to biotransformation for those of you who stay on for the next module on the weekend, energy, right, detoxification. Many of these critical functions are really hosted within the biome. And of course, when the biome becomes dysbiotic or dysfunctional, that can disrupt many of these processes, and then they can turn into different pathological entities and symptoms that we tend to chase in the medical field. In the old real estate business, it's location, location, location. The same is true in the gut in relevance to the biome. You can see on the right-hand side the schematic showing that as we descend from the stomach downwards, we see that there is a relative sterility to the upper GI tract. There tends to be more aerobes than anaerobes. And then as we approach through the jejunum down to the ileum towards the ileocecal valve and the colon, this mixture will change. It'll become a little more anaerobic predominant as we get into the colon. And certainly this is important to keep in mind because the different parts of the small bowel have a different level of tolerance to these types of microbes. And as I go through the discussion on SIBO, please keep in mind that the upper GI tract, particularly the jejunum and duodenum, do not tolerate anaerobes so well. And so when we see in SIBO, when we have a predominance of anaerobes in the upper GI tract, that can lead to a number of different manifestations, and we'll talk about that, with a more severe manifestation being enteropathy, weight loss, almost like a celiac syndrome when you do have large quantities of anaerobes in the upper GI tract. So the definition of SIBO, there is a little bit of controversy and some disagreement amongst the experts in the field, but 10,000 bacteria per milliliter of aspirate is what is felt to be the gold standard at this point in time. And that is from an aspirate of the duodenum best in the third or fourth portion of the duodenum. The closer to the jejunum you do that, the better off you are. Taking gastric aspirates certainly isn't not the small bowel, so that's not something that we tend to do. We tend to, go in with the scopes, make sure that we're in the duodenum, we can visualize that. Take our aspirates, it may take several minutes to do. I've done it both diagnostically and for research purposes. It requires some patience, but the laboratories are very accustomed to handling the duodenal fluids, and we'll talk more in detail about some of the studies relatable to that. But again, the more the mixture of the bacteria in the small bowel resembles the colon, the more trouble that's going to cause, both on a fermentation point of view for symptoms, but also it can affect the villi, it can affect the permeability, and cause other secondary manifestations that we see systemically. So we have to keep in mind there's quantity, but also there's quality in terms of being more anaerobic, rich in nature, that we keep in mind with SIBO. This is a slide that was published in JAMA by Henry Lin way back in the day when Henry worked with Mark Pimentel at Cedars. But what it shows you on the first slide is quote-unquote the normal state. And in that normal state, you can see that there is a more pink in the upper digestive tract, which is a little bit more on the aerobic side and a little bit lighter on the colonization side. So when we have easily digestible starches such as rice and also poorly digestible starches like the beans I had mentioned yesterday, as they get digested through, it's not until they reach the colon where you have more of an anaerobic mix of bacteria in high amounts that you're going to see some of this fermentation and gas production. However, on this slide below, you can see in green there is more abundance of the bacteria higher up in the small bowel. You can see in the jejunum. So you'll have a rapid fermentation of the easily digestible starches such as rice and also, of course, the beans. So this is what we're looking at in terms of the distribution that we see in SIBO and why we see the symptomatology of bloating and gas after a higher carbohydrate meal so consistently. Now, the clinical features of SIBO are quite variable and quite protean because it'll vary with the admixture of the bacteria, and also we'll talk about SIFO or with a fungal overgrowth as well. But realize that the spectrum is kind of wide from just having some minor gas and bloating in an IBS relatable type of symptomatology to when you have more of an enteropathy or when you start to compromise the villi and you have permeability issues as well. So you can see diarrhea, you can see that steatorrhea, and we'll talk about the deconjugation of bile acids from the bacteria and also the enteropathy that can be caused and giving you diarrhea and fatty acid malabsorption. And thus, it'll follow over a period of time that you can have malabsorption of the fat-soluble vitamins as a result. So you can predict what are the different manifestations of SIBO. So when you see a patient with gas and bloating and they start to emerge to have some of these manifestations, you can predict with some confidence that there's a dysbiosis and likely a SIBO subtype of dysbiosis. Okay? So what's interesting is that in IBS, there's a number of studies, and I'll show you at least one meta-analysis that'll show that the majority of patients with IBS have SIBO, which I think is quite compelling. And then once individuals are treated for SIBO, and that's evolved over time. Now, years ago, was just giving antibiotics, and there was no dietary counseling involved, there was no root cause analysis involved, and people were responding just to the antibiotics. And if they were receiving the antibiotic, although I'm not up here to promote antibiotics, but if they received the antibiotic, in that situation, people felt better. So actually the SIBO had an impact on their IBS symptomatology, which helped link the fact that there is a causality in provoking symptoms with IBS. But I think more importantly, when we talk about the interconnectivity of the microbiome to the rest of the body and the fact that when we have microbial dysbiosis, in this case SIBO, as, again, a subtype of microbial dysbiosis. You can see that it has this relationship with chronic fatigue, going back to that energy part of the Venn diagram of the matrix, and also with fibromyalgia, which is this enigmatic condition which unfortunately is in many rheumatological circles a diagnosis that they have little to offer in terms of treatments, but here there's an interconnection with just SIBO and with microbial dysbiosis that has been overlooked for many years. So what about the pathophysiology? If you want to correct or try to ameliorate SIBO, it's always good to look at root causation and understand the underlying pathogenesis so we can correct these imbalances so we can help improve outcomes. So we know that IgA, which is important for immunity, can be depressed in individuals and be a risk factor for people with SIBO. Hypochlorhydria, it would be a risk factor. Again, bile acids help protect and keep the bacteria in check. There's a relationship between the bile acids and the microbiome. There is an interrelationship. So having bile acids and pancreatic enzymes are important to keep us from developing SIBO. And the ileocecal valve, I will emphasize and actually show you our own research to show you that that is another critical factor that's been overlooked, but not in the motility community, but just in the GI community and in the medical community in general. But there are factors, and these are more epidemiological factors that have been associated with SIBO. The IBS diarrhea predominant subtype clearly is associated with SIBO. The constipation subtype, as Patrick had talked about, the Archaeobacter and Methanobacter that I'll highlight is more associated with the constipation predominant disease, but just overall you'll see more SIBO relatable to IBS-D. So keep that in mind that when you have a patient with IBS-D, they may actually have SIBO, at least that's a statistical significance. Older age, the immune senescence that Patrick had mentioned, the loss of biodiversity, the diminished immune responses that we see as we age may make us more susceptible to SIBO. And there's a condition maybe 10 years ago that got coined of SIBO of the elderly, when SIBO started to become recognized as a diagnostic entity. And of course, PPIs, arguably, there's been several meta-analyses. I'll show you one that is negative, but there are several that is positive to show that PPIs are a risk factor for that as well. And of course, in the situation where you have narcotics and you slow small bowel transit, then you're not clearing the bacteria as rapidly and you can be susceptible to small bowel overgrowth as well. So that all will be put into perspective. I'll show you a study we did using SmartPill to define that the small bowel motility is slow, and there's opportunities to improve that with both herbs and acupuncture, and also this medication that got approved recently called prucalopride. So I mean, there are ways that we can treat this, or low dose erythromycin. There are ways to improve the small bowel motility. So it's not just some kind of knowledgeable pathophysiological finding that we can do nothing about. That is actually not the case. This is a little bit of a more detailed view of the slide I had shown you earlier on, to say that we have a definite mixture of bacteria through the gut, and we go from a lighter, more aerobic mixture down to a more richer anaerobic mixture as we descend forward, but realize is that we do these stool analysis which give us a kind of a snapshot of what's going on, perhaps in the colon, but it's not until more recently we've done more studies on small bowel aspirates that we look at how the microbiome in the small bowel is a little bit different as well in terms of its biodiversity and its populations. So again, it's a subtype of dysbiosis, and I think the important thing to realize that in SIBO itself, it's not just about the quantity, it's actually about the types of bacteria that tend to be present. There are a number of studies that maybe vary to some extent. Mark Pimentel had one that he presented at the Digestive Disease Week this May and will be published later this year, God bless you, is showing that we have more of these polymicrobial mixtures, but Enterococcus and bacteroids tend to be predominant in most of these studies that we're looking at. So the concentrations are higher. And again, as I mentioned, the small bowel transit tends to be delayed. So it's like a combination. You have some type of immune senescence, you have a delay in motility, the bacteria find a home to thrive, and they're not being cleared out. And in the setting of hypochlorhydria, pancreatic insufficiency, they're allowed to start to stagnate and grow, and that'll start to break down the gut barrier, and you can see a number of different systemic manifestations that can result. Again, in the setting of individuals who we suspect have celiac disease and they malabsorb, particularly those with IBS-D, where you see more of SIBO, you can see actually a blunting of the villi. You can see actually a gathering and increase of these intraepithelial lymphocytes, and we see a number of people with increased intraepithelial lymphocytes who do not have celiac disease, and they turn out to have SIBO. So SIBO is this inflammatory type of condition as well, that we can see the gathering of these IELs or intraepithelial lymphocytes that do not belong. And so we see the vicious cycle that ensues, right? We see an IBS-like picture and itself having a linkage to IBS. And at the end of the day, it's again these bacterial byproducts and toxins that help break down the villi, break down the tight junction. And in the setting where you have hyperpermeability, their endotoxins can then circulate through the body and cause all kinds of havoc. So we talked a little bit yesterday, we talked about the digestive insufficiencies and malabsorption. We talked about fatty acid malabsorption and how to test for it. And as we discussed, the way we absorb fats and assimilate fat is by micelle formation. And certainly when we have, and bile acids and bile salts being critical to that, in that micelle formation for long-chain fatty acids. But unfortunately, what we see here is that in the setting of SIBO, that will uncouple or deconjugate the bile acids, and you can then disrupt the absorption of fat. So we can see individuals with actually fatty acid malabsorption, not only from damage to the villi, but also from the deconjugation of bile acids. It's important for you to understand the pathophysiology and why looking at fat-soluble vitamins is particularly important. Realize that when you have these free-floating fatty acids that are not being bound to bile salts, you have an increase in these long-chain free fatty acids in the gut, and they can bind to minerals like calcium and magnesium. You can form soaps inside the gut, and therefore you can have hypocalcemia, hypomagnesemia, and those manifestations long-term as well. B12 becomes insufficient for two reasons over time. One, because the bacteria love them and they metabolize them. And then secondly, your ability to have B12 intrinsic factor detach is impaired because of the bacterial overgrowth as well. Folate is kind of interesting. On board exams, they love to ask us questions when we have an individual with elevated folate. In the setting of SIBO, the trick question there is that actually the bacteria can make the folate, so you can see higher folate. But in any event, just realize that folate levels don't tend to be suppressed in this condition. And if you have villus damage, and you have protein malabsorption as well, and you have sloughing of the villi, you can have long-term protein malabsorption and protein losing enteropathy. And iron deficiency anemia would be quite rare, but can happen as well. So as I mentioned, here are the many faces of SIBO and the secondary manifestations, again, relatable again to the fact that this is a dysbiotic condition of the gut, breakdown of permeability. If you measured LPS and endotoxin, you would find out to be elevated in some individuals, and therefore they can cause some of these extraintestinal manifestations such as bloating, fatigue, associations with depression through the mind-body, the gut-brain axis. So realize that these interconnections in someone in your clinic who has gas and bloating and low energy, which we see very commonly in IBS. In fact, it is part of the IBS quality of life questionnaire. There's several questions about I feel fatigued, I don't feel I'm able to do my activities of daily living. They all relate to low energy, and that's one of the first things people will tell you is that I don't feel well, I have low energy, and then tell you about their gut symptoms. So as we kind of move forward, realize that we have a number of different etiologies that make sense. We have, I just have to take a drink. Not the drink I'd prefer, but for those who watch the stock market, coffee is up today, so get the coffee while it's free. I had to get a joke in there somehow, but just warming up. So, you know I don't like PPIs, right? You'll see them on like most of my slides. Anyway, when you suppress hydrochloric acid, when you alter the gut anatomy with bypass surgery, I mean, these things can make you susceptible to SIBO. So we see individuals with gastric bypass, and there is what they call a blind loop that gets formed in the gastric bypass. The microbiome initially gets better over time, and it actually shows, you can see people's glucose tolerance improve within 24 hours of gastric bypass surgery. The microbiome actually becomes more biodiversified, but over time with the blind loop, that can lead to SIBO. And there's studies showing that individuals who get certain probiotics to improve the SIBO actually have facilitated weight loss as you biodiversify the microbiome. So realize that the surgeries are kind of they have a dual outcome for weight loss, but also you have to realize that there's more susceptibility to SIBO. Collagen vascular disease is associated with a slower small bowel transit, and that'll lead to SIBO. Immunity is changed, obviously, with autoimmune diseases. You can see on the right a number of different manifestations are associated, and we just didn't have enough room to list it here. But realize with small bowel diverticulosis, again, you have stagnation. Anything where you have stagnation in the small bowel can make you susceptible to SIBO and or immunodeficiency and or autoimmunity. So I think once you follow those rules in the back of your mind, you can pretty much make the connection of individuals who come to your office who are at risk for SIBO. And now in this particular slide, you can see that when you look at the relationship of SIBO to IBS, the odds are is that you have about a 56% or so probability that if you have an IBS patient in your office, they have SIBO. And you have to realize the range is wide. Some of these showed like 70, 80%. So, but on the average, you can see it's about 60%, which is pretty good. I mean, the odds are if you breath test your patient, they'll be positive. And in my clinic, I have about a 70% positive rate of breath testing for SIBO. So again, we have a 3 to 5, the odds ratio is between 3 and 5. And in this one study in 2018, they did a meta-analysis, and they did show these different risk factors. They did not find PPI use, but they're in a minority of the different meta-analyses that are out there. Okay, so the old adage was that there is a lack of interconnectivity, and as part of what we see in what we're doing here at IFM, we're looking at that there is an interrelationship and interconnectivity of these conditions through the biome. At least this is a growing list in terms of the different conditions that have been epidemiologically linked to SIBO. I have to give my hats off to Kirsten Ramsell, who has really helped me creating these beautiful slides, but also keeping up with the literature as well. It's a daunting task in the GI field, particularly in the microbiome and SIBO. So we have here is how do you diagnose SIBO? Well, I mean, the physical exam, people tend to show you real-time videos of how they bloat after a meal. You've had patients show you those videos real-time, come to your office and bring out their iPhone, and besides showing you the stools and all that they like to show you or show off, I'm not sure, but I don't know, you're all awake. Even Diego's awake today, right? There you go. Who's going to win tonight? Houston or the Nats? Houston? All right, we'll see. Okay. We'll have a little wager later on. But in any event, he was from Houston, so we have a little bit of a disagreement because I live by D.C. Dan likes baseball talk, so I figure I'd, give Dan a little smile back there. But in any event, so we have these non-specific findings, right? They get bloated, they get distended. But if you look a little bit deeper, you should look at their B12. I look at B12 on all my patients who I suspect SIBO, and I'm very surprised. I shouldn't be so surprised, but I see a lot of people with B12 less than 300 with SIBO symptomatology. So I would do that. I wouldn't have to go into a methylmalonic acid to see if it's impending. If you see it's 300 or below, they're B12 insufficient. I wouldn't worry about doing a folate. That's more academic. But I do breath testing, and I'll really tell you that for us, it's the gold standard, because who wants to do endoscopy and do cultures on everybody? It's just unrealistic. It's expensive, and no one's going to pay for it. But it tends to still be the gold standard in the literature. And what they do, or what we do, is that during an endoscopy, we put a little plastic tube through a side channel. It goes into the small bowel. It's sterile. As it goes in, we aspirate about 5 to 10 mils of fluid from the duodenum. It takes a little bit of while. The scope itself is a stimulant to the fluid collection. When you go in there isn't 5 or 10 mils of fluid just waiting for you. It would be beautiful if that happened, but it doesn't happen in reality. You have to wait because the scope itself is a stimulant, and the body tries to tend to secretions and has waves of motility to get the scope to do something different, but stand there, and it kind of drives you nuts as you're looking at this, and you collect the fluid, you send it to the lab, and do serial dilutions, and they do some quantitative analysis. Alrighty, now breath testing is kind of what we do a lot. I mean, for those of you who don't work at an academic center, bless you that you don't, but I was actually recorded. I shouldn't have said that, but in any event. Yeah. So you can actually take a kit and you can send it out. And so what you do is you do a breath test analysis. You will have your patients have a kit sent to them by a laboratory, or if you have a breathalyzer laboratory more locally to you, they will drink a fluid. We'll talk more about the sugars that are available. And then over a 3-hour period of time, you'll be taking serial measurements of their breath, hydrogen and methane every 15 or 20 minutes, depending on the laboratory, and you'll generate a curve that'll look at methane and hydrogen fermentation. That's pretty much the crux of it. As you can see on this slide, this shows you a little bit of what we would look at, that an individual would start to rise in terms of their breath, hydrogen or methane over a period of time, and 90 minutes is the gold standard. So when we look at, and also we look at baselines as well, and the criterion are kind of mixed. There was a North American, believe it or not, guidelines that were just formulated, and they're a little bit still vague on baselines. Usually we want to have a baseline under 10 parts per million of hydrogen or methane. Some people are elevated because they have SIBO. Some people are elevated because they cheated and they had pasta the night before, or didn't prep well, or have gastroparesis and have food in their system for quite some time. In that situation, you would do a repeat breath test. But here, the rule is that if you start to see this rapid fermentation within 90 minutes, then that's most likely SIBO. You can use either glucose or lactulose. Glucose tends to be more specific. Lactulose is a little bit more sensitive. This shows you a little bit more real time. Again, you can see that this in particular is hydrogen. You can see that it is, again, at the 90-minute mark above 20 parts per million. And we try to look at the delta being baseline minus the value at 90. this case, it would be 40, and that would be certainly way over the 20 guideline. For methane, we're looking at more or less around 12. Other centers look even more scrupulous at methane, that even if they see it's 3 to 4 above baseline, they would treat. But, based on guidelines, we would go with around 12. This slide just kind of gives you just a nice overview. It's from a publication in 2017 showing in situations with SIBO. Here we have the pathological abnormalities that are associated with SIBO, some of the risk factors, and then here you can see that if you have an IBS patient versus healthy, is that the odds of having an abnormal aspirate for SIBO is 23%, but if you did glucose breath testing, which is very specific, it would be about the same figure. On lactulose breath testing, it's more sensitive, so the figure would be much higher. So, as you can imagine, the idea of having the hydrogen and methane produced as a byproduct of fermentation. However, just realize in terms of methanogens, Patrick had mentioned archaea, but there are other bacteria that can also make methane. But again, we're looking at mainly Methanobacter as being the source of the methane. So we're looking at different subtypes. I think it's important to keep in mind that there is either a hydrogen predominant, right? You can see here that there is hydrogen predominance here. Here you can see that there is methane predominance. And here you can see there's elevations of both. So we tend to we treat based on different subtypes. As Patrick had mentioned, methane is a little bit more stubborn and resistant to treatment. We'll talk about those treatment options a little bit later on. Hydrogen can correct with lifestyle modifications, with diet, depending on their chronicity and their underlying pathophysiologies, and some antimicrobials. Methane really requires a full court press. Hydrogen sulfide is a big unknown. I'll show you how we empirically diagnose that, and we'll show you data from Pimentel on rifaximin. This is just to show you that we have something called a Bristol stool chart shown on this slide that we tend to use in the clinic. And you can see that people who are on the looser side, or the subtype 6 and 7, tend to be more positive on their breath hydrogen testing. So again, this is that association with IBS diarrhea. Again, when we do breath testing, we have hydrogen-producing bacteria. Hydrogen becomes a source for methane. So actually, the hydrogen then becomes used by methanogens to make methane. Or we can have the hydrogen actually become hydrogen sulfide with sulfide-reducing bacteria. Or we can have acetogenic bacteria make acetate, and Patrick had mentioned that those acetate can actually help enrich the biofilm. So you can kind of see how we can subtype people based on their breath testing. This is actually kind of newer material over the last 2 years. This hydrogen sulfide pattern that we're seeing is when there is absolutely no or a flat response to the sugar. So we give either glucose or lactulose, and you absolutely see no response even in the colon. That tends to be a pattern of hydrogen sulfide because you're not making either hydrogen or methane, but that's being shuttled or converted into hydrogen sulfide. We always hear that there's people developing tests for hydrogen sulfide, but we haven't exactly seen this yet. I'll just finish up by just running through briefly a case report by which we identified a CFO, and this is around the time where CFO became more and more popular in the literature. And just overall, this was an unfortunate lady who had Sjogren's syndrome and had prior surgeries and multiple risk factors for dysbiotic, let's say small bowel dysbiotic overgrowth, and was having a protein-losing enteropathy, was losing weight and wound up on what they used to call TPN, or central peripheral nutrition. So she was getting IV nutrition from a wasting syndrome that nobody could really, at that point, figure out. So we had her in the hospital. We did a fluid analysis, found out that she had SIFO, or small intestinal fungal overgrowth, and she actually did quite well when she got treated with antifungals. So again, we're seeing a lot of people, and now there's a series. There's a gentleman called Shital Shrao, who used to be the head of GI at University of Iowa. He has subsequently moved. And what we all realize is that even the setting of SIFO, that individuals may be at risk from PPIs and also from a small intestinal dysmotility. So the technical diagnosis is a little bit different. It's only 1,000 fungi per mil of fluid to make the diagnosis of SIFO. Again, you do it during endoscopy, you collect the fluid. We don't have really other great ways to diagnose SIFO except empirically, and we can even see this in the large bowel, and we see, of course, in our population, we see a lot of people with candida overgrowth. So this shows you the relationship that you can have, just like with breath testing, you can have hydrogen, methane, or both. You can have either SIBO alone, SIFO alone, or a combination of that, or even with the large bowel. Here, this particular study coming out of Dr. Rao's clinic had showed that at least when you have 150 patients who present with the typical IBS symptoms, that over about 2/3, or about that 60% mark, had some evidence of microbial overgrowth. And again, you have an admixture of people who just have SIBO, who have a combination of SIBO and SIFO, or just have SIFO alone. So there's a lot of people being missed with SIFO, and those are the people who may not respond so well to typical SIBO treatments. Even after colectomy, we see people who undergo surgeries for Crohn's and/or colon cancer. You can see colectomy be a risk factor that involves the ileocecal valve for SIFO. Again, this is in summary. Here are the causes and consequences. You've seen this before. On the left are all the different risk factors, and on the right are the consequences, and they're quite enormous. And so realize when you see a patient with these typical symptoms of gas, bloating, diarrhea, think about SIBO, think about breath testing, and when they have some of these extraintestinal manifestations, depression, arthralgias, chronic fatigue, fibromyalgia, you can actually make some improvements by shifting the biome, and we will talk more about that in subsequent lectures. Thank you.